So today, listeners, I am so thankful to have Dr. Jazi with me. I met him at a recent psychotherapy conference, and he is a psychiatrist who actually knows all about therapy, which many don't. So it was really, I felt very fortunate to meet him, and I got to see that he does some very similar work to what I do. And we kind of had maybe a connection in that way, which is focusing on the importance of experiencing and expressing our emotions. And it was really cool because he presented at this conference and I got to see, and I actually, Dr. Jazzy, I don't know if you know this, but it made a lot of us cry in the audience. I was one of those people. And I found out later a lot of other people cried at the same time, but it was so beautiful to just witness the work firsthand, the video of you with your client. And he works especially with seniors. And so it was really beautiful just to see this older woman be able to feel liberated and experience catharsis by expressing these feelings out of her body working with you. And so I just wanted to invite you here so we could talk more about this commonality, and maybe, more people will move towards this.
So, hi everybody. Hi, Bronwyn. Thank you very much for your kind introduction. And yeah, this is Dr. Ali Najafian Jazi. I'm a psychiatrist and a psychotherapist. And it was really nice, a pleasure meeting you at the conference. And it's a pleasure to be here in your podcast. Thank you for the invite, and welcome everybody who's listening to this.
Yeah. So, yeah, it was so refreshing, Dr. Jazzy, because so few therapists, especially psychiatrists, seem to know much about emotions, honestly. And to see your presentation where you are just showing your work with this woman and being able to see her, she's in her, I believe she was in her 70s, or was she in her 80s? 80s. Yeah, just, I don't know. I think she said she herself was a psychologist or in the psychotherapy world at one point. And yet she probably really hadn't been able to express herself until that session with you.
Yeah, yeah. I do work with both young people and older people, and both of them my psychotherapy. I think depth psychotherapy is
Mm,
what the people who are seeking help from a
mm,
mental health provider is that what they deserve really. So
yeah.
the problem is that a lot of times we see that we hear that from the clients that the emotion is a problem. However, emotion is not the problem. Emotion is the solution to the problem.
That's
So, what
right.
is the underlying problem? So, a
Hmm.
lot of people, because they cannot handle the emotions very well, because
Hmm.
they are not aware of their emotions very well,
Yes.
because the emotions are sometimes very heavy and
Hmm.
they can be very negative, and at
Hmm.
times they can be very positive, but not being handled very well. That can easily cause distress. It can cause mental distress. It
Hmm.
can cause even physical distress, which we
Yes.
usually call psychosomatic somatization
Hmm.
disorders, for
Hmm.
example.
Hmm.
So, by acknowledging that we have some emotions and those emotions are important. There's a purpose for having those emotions.
Yeah.
So if we can help the clients or the patients to get in touch with those emotions,
Hmm.
and it is a difficult process, and it is a process I have to emphasize.
Hmm.
Throughout during that process, when they are working with a therapist like you, like me, like other therapists, they start understanding that what is wrong and what is the actual problem, why those emotions are so hard. What is the underlying pathology? Usually going back to relationship. A lot of times, I mean, these emotions, patients can carry these emotions for decades.
Oh,
In
yeah.
people, it can be decades. In younger people, maybe shorter time, but it doesn't matter. I mean, the
Hmm.
length is not important. The importance is that it
Hmm.
can it can harm you. It can harm patients, and it
Yes.
does, unfortunately. So that's my philosophy for the work, that I do help people to get in touch with their emotions. That's what I usually try to do, and I adore doing with a lot of clients. Yeah.
Yeah. Yeah. Well, I'm curious though, it's so rare even among, I mean, among all clinicians, I would say, you mentioned that, other people are working through insight to give insight or coping skills or
Mhm.
acceptance, what we call radical acceptance. Those seem to be like the other kind of branches or ideologies. And those aren't bad things, certainly. But why is it, would you say, in your experience, most therapists at every level kind of really don't know what to do with emotions? We ourselves don't seem to understand that they are the solution, not the problem.
Mhm.
Like, what was your experience? I'm just curious your own
Yeah,
journey, how you got here.
sure, definitely. So, a brief answer to this question, and then I tell you how I got to this work. I mean, first of all, there are some technical issues. Yeah, there might be. But I think more important than technical difficulty of helping such patients helping them to get in touch with their emotions is the therapist, their own emotions too.
Mm.
It is a mutual. We have something called transference,
Mhm.
countertransference. So it is difficult, and a lot of times when the patients start not resisting, so it affects the course of the therapy. So understanding the patients and how they are using their defense mechanisms to suppress those emotions, and
Yeah.
how the therapist may use the defense mechanism to suppress the emotions, and we don't want that the therapy and the patient, that they become hand in hand, they become a team member suppressing each other's emotions, or at least the patient's emotions.
Yeah.
So that's very important to keep in mind. So about myself, so I'm a psychiatrist. uh, I did my residency in Virginia, Southern Virginia. It was a lovely place. And then I did a geriatric psychiatry fellowship at UCLA. So even during my residency training, I was working with some of our attendings that they did a lot of in-depth therapy. I
Mm.
was I was recording, I mean, not videotapes in those years, I mean
Mhm.
just tape recorders, just a
Mm.
voice.
Mm.
And I did the supervision with some of my attendings. Uh, I was feeling that we don't have, unfortunately, the enough knowledge of how to treat a lot of conditions only with medication.
Yeah.
It is impossible. We don't know a lot of different receptors that are working there to just cause this emotional problem that, for example, one patient is dealing with,
Mhm.
psychiatric or psychological issues that they're dealing with. It is really multifactorial.
Yeah.
So that's why from the beginning, from get-go, I was thinking that psychotherapy is something I would like to do. So definitely,
Mhm.
in addition to my uh, usual psychiatric
Mhm.
treatments.
Mm.
And during my fellowship, I met with one of my supervisors that you, I think, met him as well, Dr. Brandon Yarns. And
Yeah.
then I got introduced to some type of dynamic psychotherapy,
Mm.
ISTDP. And I'm in supervision by videotaping, showing them to my supervisors, Dr. Brandon Yarn, Dr. John Rathhauser. And that's how it's all about practice. So I did a lot of practice for several years.
Mm.
Uh, in learning how this emotion focused work is being done and how it can help the patient. So you mentioned very important thing about other modalities, other
Mhm.
techniques like
Mhm.
CBT, like
Mhm.
acceptance,
Mhm.
finding coping skill,
Mhm.
very commonly insight building therapies. So they're good, of course they are, but in a lot of cases, I don't see them adequate.
Mhm.
Because sometimes I look at it this way, because sometimes even a coping skill means that you are avoiding those emotions.
Yeah.
Sometimes by knowing something because you have a good insight, it means that you are avoiding the deep work.
Yeah.
How many patients or clients have other therapists or psychiatrists, seen that for example, they do have OCD,
Mhm.
obsessive compulsive disorder, and
Mhm.
they do have a very good insight about it. They come and say, I know this is wrong. I
Mm.
know I shouldn't wash my hands 100 times a
Mm.
day. What
Mm.
is wrong with this? Why can't I stop?
Mhm.
So there are a lot of underlying feelings in any of these conditions, even conditions like OCD, which we know, for example, CBT or exposure response prevention is very good evidence-based treatment for it. But even then, there are a lot of emotional work that can
Mhm.
facilitate other
Yeah.
modalities to work better.
Yeah, I'm not a fan of CBT or anything but what we do for everything,
Mhm.
including OCD. I've actually seen
Yeah,
people completely ameliorate their OCD
yeah,
with emotion, expressive emotion catharsis in therapy. Um, but I think it's interesting. You kind of named this earlier. You know, I've heard, I remember when I was just training, when I was getting my hours, I remember hearing supervisors say, you don't want to open people up. And then, like, the 50 minutes is over and they're just like dysregulated. And then you got to close the session. It seemed like everyone was so afraid of opening people
yeah,
up and they're going to get dysregulated. Like, it created like this fear in me, including in me. But I also remember thinking, then what are we doing if we're not opening people up? Like, why are they coming to therapy if they're not
yeah.
going to connect with their feelings? And I do think there is a fear that of people's emotions, of our own emotions, like you were kind of insinuating, as we practitioners are afraid of our own emotions too,
Mhm.
and we project that countertransference. There's
Yeah,
just a misunderstanding, but even more, I think, a lack of our own healthy experience with emotions. And you said negative emotions. I actually don't like calling any emotions negative. I understand what you're saying, but I like to say there's emotions that feel good and there's emotions
mhm.
that don't feel good. They're
Yeah,
they're
exactly.
uncomfortable,
Hmm.
but even though we aren't comfortable in the moment, they don't
Hmm.
last long when we're
Yeah,
finally letting ourselves feel them. And then at the end, we should be feeling so much better,
yeah.
after we outlet those emotions. So they're not negative except for maybe a few seconds.
Yeah, negativity, I mean, it doesn't mean that they
Mm.
are something harmful or bad or they shouldn't be there.
Right.
Unfortunately, a lot of people call it negative. So
Yeah.
that is why I use the word negative. But
Yeah.
even look at anger. Very
Mhm.
positive, very protective. Why do
Yes.
we become angry? Why do we become angry? When there's a problem, when there is something that is attacking us, when there is something that might harm us. So we
Yeah.
need to protect ourselves by the
Yes.
feeling of anger.
Right.
Even sometimes we do have, I mean, rage. We have the
Yes.
feeling of rage.
Yeah. Yeah.
But uh, of course, we should not act on any of these emotions in public or in somewhere that there are other people or harming others. But it's okay to have those emotions and feel them. You know,
Right.
I like what you said about not becoming labeling emotions.
Mhm.
Uh, there are some other type of, I mean, naming like unhealthy emotions. For
Mhm.
example, I would call shame a very unhealthy emotion.
Yes.
There's no reason why. I mean, say someone has done something wrong. For example, a child did something wrong because
Mhm.
they either didn't know it or they just did something wrong because they wanted to do something wrong. They
Mhm.
wanted to disobey or whatever. So,
Yeah.
but what the authority figure, usually parent, does,
Mhm. Mm.
unfortunately, is that they may, instead of educating them about what they
Mm.
have done,
Mm.
in case of helping them to go through the feeling of guilt because they have done something wrong.
Mm.
Okay, so that might be guilt.
Mhm.
They induce shame.
Yeah.
So, as a punishment,
Yes.
the punishment can be, I mean, other types, but inducing the shame, it becomes a template or a pattern,
Mhm.
a very unhealthy one. So,
Yes.
in later on in adulthood, even older adulthood, the person starts thinking, oh, I did something wrong. Instead of feeling the actual guilt, they
Mm.
may start feeling shame. Or if the person makes them feeling ashamed because they just didn't know what is the
Mm.
right thing to do, they
Mhm.
should start feeling anger.
Mm.
But instead, they start feeling shame.
Yeah.
So that is, unfortunately, I mean, it happens a lot in
Yes.
relationships. In a lot of time, relationships all over, I mean, throughout the life, not just early life, later in life as well.
Mhm. Yeah, I don't actually call shame an emotion. I call it a feeling because,
Mhm,
you know, babies are born into the world with all the emotions, but they're not born into the world with shame.
mhm.
Shame is from other people. Shame is
Yeah,
learned.
it comes from other people. Like, it is induced. It provokes. They provoke it, unfortunately.
It's manipulative, really.
Yeah, it can be definitely. Yeah. And not that every time they just do it intentionally. A lot of time they
Yeah.
don't know better, you know.
Yes.
And in the process of therapy, if this client understands that it is shame, it is unhealthy, instead I should have been very angry, or I should have been feeling the guilt, I should have apologized, or
Mm,
I should have, told the person that why this happened. Instead, they start feeling the shame. In the therapy process of therapy, if they know that no, this is wrong, I shouldn't feel ashamed, I did wrong, or I didn't do anything wrong. So
mm,
either guilt or anger, simplified version.
yeah. Yeah.
So that is going to help the patient or
Hmm.
client that to rewrite their own story and
Yes.
feel differently in different situations because these patterns are not just sitting there. Every time in daily activities, in relationships,
Hmm.
similar things happening and trigger them, trigger
Yeah.
the same pathways.
Yes, that is so true. Yeah, so I know you watched one of my videos,
Yes,
my training videos. I don't know if you saw the one where I teach therapists to do this, but I always have clients put their shame in a cardboard box and give
mhm.
it back to the person who gave it to them. So it could
Yeah,
be the parent, the bully, the
mhm.
teacher, whoever it was.
Yeah,
Um, because shame tells us we can't be human, that we're not human, that we're not allowed to be
yeah,
human. And humans, we make lots of mistakes. That's what
yeah,
humans do best.
exactly. Or we are not allowed to feel the anger,
Mhm.
or as you said, we are not allowed to feel the guilt. you
Mhm.
know? So
Mhm.
instead, that person could just receive empathy or
Yes.
just kindness. Or
Mhm.
even if it was a punishment in a way that was, yeah, something was wrong, a lesson was given, you know? A, a lot of different ways that could be done productively.
Yeah.
But yeah, it has happened to everybody. But
Well, yeah, so I shame is not productive. You just said
yeah,
it could be productive or it could not be. And shame is what keeps everything from being productive. It
exactly.
stagnates us, it
Yeah.
stifles us, it makes us stuck. Where emotions, like the real ones that humans are born with, that are native to us, are actually, I like to say, they're called emotion because they're there to move us. They move
Mhm.
us
Yeah.
with, what do I need right now? I
Yeah.
need to have an assertive talk with this person. I need
Yes.
accountability, right? I need to have a boundary with this person. But shame doesn't move us. It just makes us stuck and it debilitates.
Yes, exactly. I agree with that. It's very important that the client can understand in the course of therapy that what is the right thing to do. When a child becomes ashamed for whatever reason,
Yeah.
what they use their defense mechanisms to
Mhm.
just suppress that anger, make sure that the anger is away because it could worsen the situation. They already received the punishment of being ashamed, which is a very uncomfortable feeling. So
Yes.
they push anger away, they push
Yeah.
guilt away, they suppress
Yes.
it, and
Yes.
they continue. And then they see, okay, it worked. It worked. By suppressing my anger, it worked. Parent didn't punish me more. They actually came and hugged me. They actually helped me.
Mhm.
So it
Yeah.
worked. And then gradually, if it becomes a pattern in the
Yeah.
similar situations,
Mm.
it becomes a pattern using
Mm.
the defense mechanism to suppress your emotions. It becomes a pattern
Mhm.
until the end of life. People can carry that.
But those emotions are still there.
They are still there. They built up and they will explode one day.
That's exactly right.
They exactly explode at a time that something has happened in life, a death, a tragic event, a divorce. I
Mhm.
don't know,
Mhm.
severe sickness,
Mhm.
aging,
Mhm.
significant,
Mm,
somatic symptoms. Yeah,
mm,
losing job, you name it. There are a lot of incidents that can happen in
mm,
life, and all together they bring those unhealthy
mhm,
emotions and the active use of those destructive defense mechanisms to the
mm.
surface.
Yeah. Well, I like to say that emotions don't just dissipate, they stagnate inside of
Yeah,
us and they
yeah,
make
they
us
do.
sick. They
Yeah,
make us sick.
yeah.
Mm,
And that's why I think in therapy, we need to help the patient to liberate themselves from
mhm.
these type of emotions
Yes.
because they're holding into them, just keeping them like a secret is not going to work,
Right.
and not being aware of them not going to work. And one other thing that's I think important to our discussion
Mm.
is the conflicting emotions.
Mm.
We have a lot of conflicting emotions. So
Yeah.
you love someone, but that person
Yes.
does something like a parent, that person, or like a child, that
Yeah.
person does something
Yes.
very inappropriate, or
Yes.
even if appropriate, in that mindset of the person, it is not a good thing. So
Mm.
what happens is that you
Mm.
love them at the same time and you hate them at the same time.
Yeah.
It is conflicting. It is very
Yeah.
conflicting. It is a significant ambivalence. And
Yeah.
this ambivalence can definitely cause a lot of intrapsychic conflict, which can cause a lot of psychiatric symptoms, psychological symptoms,
Mm.
OCD. And one of them, I mean,
Uh,
it just based on ambivalence. Did I wash it? Didn't I wash it? Is it clean? Is it
mm,
not? You
mm,
know?
mm, mm.
So, so
Yeah.
helping the patient to tolerate during the therapy process of therapy to tolerate this ambivalence, the conflict between the emotions, know them, knowing them, tolerating them, and release them, experience them.
That's right. So the ambivalence too creates the shame because we here in our
Yeah,
society, you can't hate your mother.
yeah, yeah.
And I always tell people, every love relationship has some hate. Like love and hate
Exactly,
go together. Of course
exactly.
you feel hatred. It doesn't mean you're going to kill her, but you hate her sometimes or you hate a part of her. So,
Yes.
but that creates the shame because we think we're the only one who feels something like that.
Yep, exactly, exactly. I agree with that.
Mm,
It's very important to help people to go through this process. And you also mentioned in one of your podcasts, a couple of them that I listened to,
mm,
experiencing the emotions. I
mhm,
think every emotion or feeling comes with, well, we know that, not that I just think, with a lot of physical symptoms. So
mhm.
the best example would be, I mean, you go in front of, I mean, an audience, 200 people, 500 people, you want to talk, you start feeling some hot flashes, something.
Yeah,
And
yep,
that's a feeling of either anxiety, embarrassment, whatever the emotion is that in that special
mhm.
person. So feelings come with physical symptoms
Yes.
like hot feeling, cold feelings. I mean, sometimes tingling, sometimes hot pop in your stomach, sometimes you feel fire, that's noticeable.
Those are the ones we notice, but we have a lot of things that we don't
Yeah,
equate
yeah.
with our emotions, like, I would say digestive stuff
Yeah,
is
of
very
course,
related
a
to
lot of digestive stuff, exactly.
yeah.
A lot of parasymptomatic symptoms or autonomic symptoms, they can happen definitely. It's
Mhm.
not just in our uh, conscious feelings like the muscles, like, it can happen in GI symptoms, as you said,
Yes.
headaches. I
Yep.
mean, sometimes tunnel vision, sometimes
Yeah.
feeling dissociated, dissociation itself.
Mhm.
Why a lot of people with PTSD, for example, trauma victims, they do
Mhm.
have a lot of dissociations because
Mhm.
it was all they could have at the time of trauma.
Mm.
They couldn't do anything. They had to numb themselves, dissociate themselves. And it worked for a
Mhm.
short period of time. And
Yeah.
then they continue to use it unconsciously.
Mhm.
It happens a lot.
One dissociative, state that I realize a lot of people do is actually sleeping. So many
Mhm.
people like, I've had clients who would just sleep all day and come to the session and then go back to
Yeah,
sleep for until we work through a lot of things in therapy. And I'm like, oh, you're just not feeling your feelings. That's what
yeah,
you're doing, you know?
yeah. Because they want to just numb themselves and sleeping is good, but
Hmm.
then they see that they can't do anything.
Yeah.
They're not enjoying. They start feeling depressed, and
Yeah.
you name it. Yeah, I think we really need to pay more attention, all of us, to the emotions of the patients, you know, to their body language when they come to the visit, especially if it is
Mm.
in person. I mean,
Mm.
I've had patients that they may not be able to name their emotions, but they're articulating it with their body, you
Yeah.
know. And that's why I think it's very important to just observe the client
Mm.
very well during the session.
Yeah. What do you observe? Because when you say that, I think about eye contact. That's something I pay a lot of
Eye
attention
eye
to.
contact is one of the very main one. Actually, we do have a lot of defense mechanisms. And we call some of them tactical defense mechanism. Eye
Mhm.
contact,
Mhm.
losing eye contact. It happens a lot that oh, sorry.
Mhm.
It happens a lot that we start feeling uh, something that we don't like. It is conflicting. And what happens is that the patient, we look away. It
Mhm.
happens a lot that the patient looks away when you are trying to get in touch with those feelings that they are uh, uncomfortable feeling, for example.
Mhm.
Yeah. Laughter.
Yes.
Patient says something that is, I mean, it is ridiculously sad.
Yep.
And they are a victim of trauma, for example, and they
Mhm.
laugh about it
Yep.
and sing because they want to keep the faucet, they want to keep the mask on. One other example was that.
Yeah. Yep. I see that a lot.
Yeah, that happens a lot.
Mhm.
But I think if we can help the client, and it is painful, there's no unpainful treatment. So if they get in touch with their emotions, they're gonna gradually know, and they start feeling positive initially in the therapy setting, usually towards the therapist, and they start feeling, I mean, what is the problem,
Mhm.
and they can get rid of those conflicts caused by those emotions
Mhm.
and feel them.
Yeah, the feeling isn't fun. It can be painful, but I had a home birth years ago, 23 years, 22 years ago. And what I was told is it's not painful, it's discomfort, but you can do this. And I'm so glad I did. And I'm like, that's kind of how therapy is. You just go through it, you feel it,
Yeah,
and it gives release to something, and then you feel so much better. And you not just feel better, you are better,
yeah,
right?
exactly. It does
Yeah.
happen, definitely. I mean, especially, I mean, the example of the birth was an amazing one because of the its productivity. What happens after that, you know?
Well, I was told by everyone, like, you look great for just having had a baby. I said, well, that's because I didn't have any drugs. I was at home
Yeah,
and, but it's amazing. You don't, I guess maybe the common denominator there is you don't know what you're capable of until you do it, until you tolerate that discomfort and you're like, "Oh my god, I'm stronger than I thought I was." I mean, that's how
yeah.
I felt after having the birth. That's how it is with our emotions when we can express them. But, it does take, like you're saying, a therapist or someone, a friend or someone that we are
Mhm.
so comfortable with that we trust, right? Because I say what's shareable is bearable. And if we grew up without anyone validating our feelings, without anyone attuning to us, without anyone, if we got shamed for having, quote, negative emotions, we had to hold it all inside because what's not shareable is not bearable, right? And so the solution is to find someone you trust. A lot of therapists don't know what to do with emotions. They feel incredibly uncomfortable with emotions themselves.
Mhm.
And then these clients aren't going to really make
Yeah.
substantial improvement. I want to kind of circle back. You brought up the acceptance, being another modality. or insight or coping skills. And I think one of the common denominators I wanted to point out is when we therapists work with our clients, focus on their emotions and their experiencing and expressing them, we're really pointing them back to themselves more than those other modalities, right? So we're really saying, hey, I might be the expert on a thing or two, but client, you're the expert on you, and
Yeah,
your
exactly.
body is
Exactly.
telling you what you need and you can trust it, right?
Yes, exactly.
Mhm.
And one thing you mentioned about what is shareable is bearable. I mean, when the client starts sharing things, it means that they have trust in the therapist or in
Mhm.
the other person. So even if they want to share the worst possible emotions, even the harmful emotions, if they have a good trust,
Mhm.
they do it. And that's how they start feeling better.
Yeah.
That's a good thing about them. And yeah, I also would like to add something about medications you mentioned at the very beginning too.
Mhm.
Uh, Medications are helpful, no
Mhm.
doubt about it. There are a lot of studies done,
Mhm.
but not all the time. They're not adequate, as I mentioned at the very beginning. Sometimes medications can be helpful, but a lot of times adding good therapy, in-depth therapy, is going to help to reduce the dose of medication and even taper them off. It has happened a lot. I've noticed that. And sometimes, no, you have to continue the medication. There is no problem. But now it with a much better insight, with a
Mhm.
much better, I mean, understanding of your own body, including the emotions.
Yeah. Yeah. Have you had clients who want to wean off because they say that they
Yeah.
can't feel their feelings? Because I've
Yes.
had clients tell me they are the medication kept them from fully feeling their
Yeah,
feelings.
it actually happens a lot. Patients come, "Oh, I feel numb with this medication. One of the side effects of this medication is that I just feel numb. I want to have my emotions, and I love that because
Right.
when
Right.
it means that they want to be friend with their own emotions, not
Yeah.
just numb them out. Unfortunately, medication also at times can be just a band-aid. I mean, we should avoid band-aid. We should avoid the crutch. We should avoid just just cope with it, deal with it. I
Hmm.
don't think this is what the patients deserve to receive.
Well, going back to kind of our disposition or our paradigm, if we see humans as inherently self healing, and
Mhm.
we just need to create the environment where they can finally connect with their own emotions and express them out of their body, and that is going to facilitate healing. That's one view. If we see emotions as negative, as they're problematic, that humans can't heal on their own, they need something outside of their bodies like medication. That's a very different paradigm.
Yeah, I agree
Mhm.
with that. Definitely,
And
definitely.
I'm all for the first one.
And I think some people like to just take the medication, and I do respect that.
Mhm.
But what I think is going to help them more is to get in touch with themselves better and know themselves better and know how to treat themselves better with respect, like a human being with emotions. That's what I would
Yeah,
like.
because so for me, the goal of therapy is self-attachment, where they
Mhm.
become their own attachment figure, where
Yeah.
we become our own attachment figure. And so if I can view my emotions as, oh, my body has something to say that I need to listen to. Now that is, I'm attuning to myself. I'm healing my relationship with myself. I'm not seeing myself as shameful, as
Mhm.
problematic, as like I'm not scapegoating myself, right? I'm actually looking at myself as I'm a beautiful creation and I am naturally going to move towards healing. So I'm going to listen to myself. I'm going to prioritize that because I matter to me, right?
Yeah,
And that facilitates that self attachment, that self attunement.
it does. It does. And I agree with that, definitely. Uh, and I would like to say in another word, compassionate, feeling compassion towards yourself.
Yeah. Mhm.
feeling content about what you are, feeling content about the emotions that you have.
Yeah.
And as a therapist and psychiatrist, I usually feel the content when I feel the patients start, I mean, feeling that towards themselves. And
Mm.
it makes me feeling that I have done something. I've done something for this client. So they're
Mm.
gonna go the rest of the journey, maybe with my help, but usually on their own and understand uh, all of their emotions. It's very helpful.
Yeah. Yeah. So to have that disposition towards ourself is the
Yeah.
real win. Right. Yeah. It's so interesting. The longer I'm a therapist, when I listen to my clients, I just trust that they are going to say what they need to say, and it's going to
Mhm.
get to what is ultimately needed to be expressed. It might take a roundabout way, but I
Yeah.
really see that if
Yeah.
they are just talking, even though you're like, where is this going? It will go where it needs to go. And I never knew that. Like, I think we're not trained as therapists to believe that about people, that they
Yeah.
inherently will know there's something innate in them that is driving what they're sharing, and it's
Yes.
going to get to what needs to be shared and then ultimately expressed.
Yeah. I
Mhm.
think when the therapy is based on some structure, so saying
Mhm.
that, okay, do this first, do that first, 12
Mm,
session, 8 session, yeah. I
yeah.
mean, we can't follow the patient. We are just following our own agenda. And I think
Yes.
it is detrimental to therapy sessions because every
Yes.
different individual is different. I mean, we have
Mhm.
to follow the patient and they have to follow us. Not everybody can just uh, get to a point that someone else can get to in one session. Some patient may need 10 sessions, for
Mm,
example, to just
mm,
get to this similar
mm,
result or similar
mm,
feeling.
mhm.
So that's why we have different diagnoses. So that's why we have different conditions, mental health conditions.
Mm.
It is very different.
Yeah, but I think we do need to trust the natural capacity of the client, that is
Exactly.
trustworthy.
Yeah.
And I think that needs to change, honestly, within the therapeutic community, because I
Mm.
don't see much of that. Um, kind of the free association, if you will,
Yes.
that Freud termed. I don't just sit and listen nonstop. Of course, I definitely, it's a dynamic between us,
Yeah.
but they do need to feel as comfortable and safe to free associate. They need that safety. Mhm.
Yes. The safety, we provide that safety by providing an environment which is non-judgmental.
Mhm.
By, for example, allowing and encouraging those feelings that they call it negative.
Yeah.
But they're gonna understand, oh yeah, I'm allowed. Now this is not mom, this is not dad who never gave me permission to feel the anger. Oh, this guy, it sounds like that he likes me. I mean, he wants to help me, but
Mhm.
it's so difficult to feel that emotion. So that conflict starts. And
Yeah.
if we help them to resolve the conflict, they're gonna they make a very good rapport with us. And there will be an
Yes.
alliance between the patient and the therapist.
Yeah.
That is the gold standard. I think when that happens, it just smoothly goes.
Yes.
Everything comes out.
Yes. And I think about, people, when they disclose these secrets, like you were saying, that they've kept inside their whole life or what have you, I've had clients do that where they'll tell me something, their deep, dark secret, and I'll say, well, yeah, I can see why that is really hard for you to share. I get that. However, I know you're not proud of it. I know it wasn't the ideal thing to do in that moment. But, given the context of where you were at that time and all these other factors that you shared with me, it actually makes sense why you did
It
that.
does. Exactly. I mean, and that was another important point that yes,
Mm.
long time ago, you couldn't do better. You had to survive in that environment.
Yeah.
But now you're a different person. You're strong. You have more capacity.
Mhm.
You are yourself a mom or a dad. You you are you are more knowledgeable.
Yeah, and I think that's the self-compassion
Yeah,
too, is like us
exactly.
showing that compassion towards them. I mean, I'm a human. I've done things that I deeply, deeply regret. And for us to be able to embrace that part of ourselves, we can do that then for our client and say, yeah, that was stupid.
Yes.
We all do stupid things.
I agree that I mean that self-compassion is very important, very, very
Mhm.
important. And I think if a person who is doing therapy
Mhm.
feels that and understands that and help the patient to get in, help the same feeling, similar feeling, that would be very helpful. Not always, I mean, of course, needed, but I think it's very helpful,
Mhm.
definitely. So that is, I think, where the countertransference and feeling
Mhm.
the therapist emotion becomes very important. You know, it happens, I mean, all the time when people talk to each other. I mean, there are mutual emotions.
Mhm.
It is not at the time of the psychoanalysis that people are neutral. They don't even notice if the client is crying, for example, or having some emotions.
Mhm.
Yes.
Yeah, I actually had a client disclose something. It wasn't something she did, but it was something done to her. And when she shared that, I literally felt some kind of energy going through the screen from her into my body.
Yeah.
And from that day, it lasted about a week. I had severe back pain for about a week.
Wow.
And I knew it was from that session because I during the session, it was like I could almost visualize this like dark energy just coming from the computer screen into me. And um yeah, I mean there's really stuff that goes on, and we can't pretend that's not there. And we
Oh,
also
yeah.
have to do our own work as therapists, to be
Exactly.
able
I
to
mean,
offset that.
exactly. I mean, that's why I mean therapy is really energy draining. I mean, you can't just see patients, for example, back to back doing deep, in-depth therapy. It is impossible. I mean, a lot of processes needs to be done by the therapist as well. I feel that at times after
Mm,
patients. I mean, yeah, I need to just think what happened now, you know.
yeah. Yeah, we have to do our own work. We have to,
Exactly.
you know, but going back to, those other modalities, so the acceptance, the insight, the coping skills. So what I find is when we help our clients self-attune by feeling their own feelings, just having that disposition towards themselves of self-compassion, expressing their feelings,
Mhm.
the insight and the acceptance are going to come naturally
Oh,
as a
exactly.
byproduct.
Exactly. So the
Yeah.
insight comes how? I mean, for example, a client has heavy emotions, anger, guilt, love in a special setting towards a parent, for example, towards a teacher, towards a sibling
Mhm.
from decades ago. But their understanding at the time is very different from their understanding now. Now
Mm.
they are feeling those emotions that they couldn't feel those
Mm.
years.
Yeah. Yeah.
But this, with the current knowledge, they're going to
Mhm.
build a new insight. They're going to write
Mm.
the story again. I mean,
Mm.
the life story is going to be written in their mind in a
Yeah.
different, very positive way that they like it. Sometimes it is a sad story, but it is. It is life. It's not always happy stories too.
Right. Yeah. So I think, going back to kind of CBT, you know, the CBT stuff will naturally happen for clients who are regularly fostering this new disposition towards themselves of
Yeah.
feeling their feelings, expressing them, knowing they're valid, and knowing their feelings tell them what they need, so that self-attunement, that self-attachment, they're naturally going to have just behaviors that are healthier in their
Yep.
lives. We don't need to, no one needs to tell them what to do. I find a lot of, I used to be in the career, my first career was nutrition. And, it's so interesting because when my clients just naturally start to self attune, they want to eat better on their own. No one needs to
Yeah.
tell them how to eat better. They
Yes.
just do, right?
Yeah. Exactly. As we said at the very beginning, it is a process, and I think one byproduct of that process is insight building.
Mhm.
But if you dictate the insight to someone saying that, okay, this is the insight, you have to teach it, you have to learn it, you have to memorize it, you have to follow, probably is not going to work in
Right.
unexpected situations. I think.
Well, and insight is all in our brain, and yet we're dissociating from our body because our
Yeah.
body is full of these stagnant feelings that we still haven't expressed.
Yes, exactly, exactly. And it becomes very uncomfortable at time.
Hmm.
So, and knowing it is not going to help. Having the
No.
insight is not going to help because it becomes very uncomfortable unless it is I tell a lot of clients like this until when it is experienced,
Mhm.
expressed, and released, it can be
Mm.
communicated to the other party or to ourselves. And that is the insight. That's how the
Yeah.
insight is being built.
Right, right. And I love that the released. So again, catharsis. I see that as a type of closure.
Yeah.
And I believe that humans naturally, whether we know it or not, usually it's unconscious, we seek closure in every way towards everything. And
Yeah.
so to finally feel those feelings, to name them, name it to tame it, right? To
Good.
name them, to express them, to accept them, to release them is a closure, and it moves us towards homeostasis in our body.
Yeah. Uh, Another important point that you mentioned, naming the emotion
Yeah.
means it is very important. It happens a lot that a client comes to me and we're talking, how do you feel now? I don't know.
Mm.
Sometimes they tell me, give me a list of names of emotions so I choose. So it is avoidance. I mean, they're feeling very uncomfortable with that emotion that they have at the moment that they even don't want to name it
Yeah.
because probably they never were allowed to name it.
No, they
So
weren't
yeah.
allowed to. Yeah, exactly. Yeah, it does help. I have a list online. There's a list called the Soul Words list that
Uh-huh.
I have clients will look up on during therapy, and there's about 80 different emotions on there, and it's really helpful just to have, you know, specific emotions like dejected, like
Yeah.
humiliated, ridiculed, just specific things we don't normally think of, right? And
Yes.
so they'll look it over. I say, take your time, and I want you to pick at least 3 emotions that
Yeah.
you feel, and they'll be able to name it, and that is powerful.
Exactly.
Mhm.
Exactly. I think I would like to say that emotions are very important. They are not the problem. They are
No,
the path to healing.
they
They are,
are the path.
they are the path to healing.
Yeah.
So we should respect them, we should accept them, we should be very happy that we have those emotions.
Well, Dr. Jazzy, I'm happy that you are a psychiatrist who believes that, because I know I keep saying this, but I think people who go into medicine don't tend to believe that emotions are healthy in general. They tend to be highly dissociative people who live in their brain and not their body. So it's really encouraging to have people like you who are doctors, MDs, but you see the truth about emotions.
Yeah, thank you very much for saying that.
Mm.
I don't want to generalize that all MDs are like
I
that,
will.
but I would like to say that working with people who are suffering
Mm,
in our training as psychiatrists,
mm,
uh, and we see that they are having emotions, they are expressing those emotions sometimes to you, and you notice that it's helpful to get
mm,
in touch with those emotions, it is encouraging for both
mm,
patient and for the psychiatrists like me. And
mm,
I agree. I think it should be done more by psychiatrists as well. So I think therapy, psychiatry, they're all in the same field. Psychotherapy and
mm.
psychiatry, definitely.
Yeah, and that takes vulnerability, and that takes someone that we can trust to be vulnerable with.
Exactly. I agree with that.
Mm.
Definitely.
Well, thank you for being on this podcast. Is there anything you want to leave us with before we wrap up?
Thank you very much. Again, thank you for inviting me. And it was a pleasure being here. And hope to see you soon somewhere else, maybe in another psychotherapy conference.
Yeah, exactly. Well, thank you, Dr.
So
Jazzy.
thank you very much.